Greeting everyone. I am Dr. Deependra from Conceptual Orthopedic, and I welcome you all in today's connect session with Harpreet sir. And today sir is going to discuss tips and tricks of Remplissage technique. So I think this talk is going to be very important to all of you. So without any further delay, I welcome you sir on the board and I request you to start your presentation. Now it's over to you, Dr. Harpreet sir.
Thanks, Dipender. Today I'll be talking about Remplissage procedure. I think previously also we have talked about this procedure. So be I'll just brush up through the introductory part where talk about what is Remplissage and why and when we need to do, and then maybe talk more about the technique, how to do it, and what are the tips, and are there any different techniques, and what's the best way to do it. So, Remplissage. Why do we need a Remplissage procedure? We already have uh, a Bankart's repair when there is only a soft tissue lesion, the Bankart's lesion, when there is detachment of the anteroinferior labrum. And we also have the Latarjet procedure when we have a glenoid bone loss. So we already have a procedure which deals with the soft tissue lesion. We already have a procedure which deals with the glenoid bone loss. So what's the need for another procedure? So the need is because both of these procedures do not actually deal with the humeral head defects. So these are dealing with just the labral tears, and they are dealing with just uh, the glenoid bone loss. But humeral head defects also can cause or increase the chances of your instability. We already have multiple amounts of literature, like Bolio told us that there was increased instability with large size of humeral head defects. And Sikea also told us that humeral head lesions greater than 25% articular surface area increase the risk of instability. So, a humeral head defect is an independent predictor of increased instability in shoulder pathologies. But it was not until the concept of glenoid track came that we could uh, measure this humeral head defect properly, and we could talk about pre-operative measurement of this uh, pathological lesion of instability. So, with this concept of glenoid track, we could accurately determine pre-operatively which humeral head lesions needed to be dealt with and which did not need to be dealt with. So, what is glenoid track? This concept was given by a famous author by the name of Itoi. So, Itoi is a Japanese author, Japanese shoulder surgeon Yamamoto and Itoi. They came up with the concept of glenoid track. They said that when you take the arm in abduction, external rotation, and horizontal extension, and take it through various degrees of rotation, there's only a path, there's a track through which the humeral head and the glenoid interact. So glenoid makes a track or moves through a track on the humeral head, and that is a very predictable path, and that is the path of articulation through which the glenoid and the humeral head interact in abduction and various degrees of rotation. This path, this area where the glenoid articulates with the humeral head during abduction and rotation is known as glenoid tract. And they found out that if the hill sacs is in the glenoid tract, so that if the hill sacs is somewhere here, if this is my glenoid tract, the hill sacs is between the glenoid tract, it does not lead to extra instability. So a on track lesion would not uh, increase the chance of instability. While if the humeral head lesion was outside the tract, partly or fully, then it would cause more instability. So this is called a on-track lesion or a off-track lesion. We have to understand the glenoid tract or the articulation of glenoid with humeral head starts from the medial edge of GT. So if this is my GT, this is my GT. So where my cuff attaches, which is my cuff attachment here on the GT. So glenoid tract starts from right here and goes medially. And this is very accurate, it can be very accurately measured. So as we said, if the glenoid tract falls, the covers your Hill-Sachs lesion, it would be an on-track lesion, it would not cause instability. But if it is not totally covered by the glenoid tract, it would lead to instability. Previously, the on-track lesion was called non-engaging lesion, and the off-track lesion was called engaging lesion. So to understand this concept is just take a look at Dipender's BMW car, and he's driving this car in Kathmandu, and there's some potholes there. Dipender follows, drives his BMW by rules, just goes along your median, along your drives very close to the midline of the road. So imagine if there's a pothole in the road, big BMW tires, 18 inches tires. If the tire is able to cover the pothole, if the pothole is small and the tire less than 18 inches and it goes over the pothole, there will be no jerk. So there will be no instability. But if the pothole is way away from the median or it's a big hole, 20 inches pothole, then there will be jerk as the Depender's car goes over the pothole. So this would be a off-track lesion because there'll be a jerk, there'll be instability. So medial, two medial Hill-Sachs lesion or a pothole would lead to instability, or too big a Hill-Sachs lesion would lead to instability. A small and a lateral Hill-Sachs lesion or a pothole would not lead to instability. That's the easier way of understanding that. That's for concept. How do you calculate glenoid tract? So we know glenoid tract by various experiments. The glenoid tract is equal to 83% of your glenoid width. So this has been measured in various papers on cadaveric studies, in human studies. So glenoid tract amount of articulation of glenoid with the humeral head is 83% of your glenoid width. And if there is any glenoid loss, you have to minus this amount of glenoid bone loss from this 83% of glenoid width. So 0.83 of glenoid width minus any glenoid bone loss. So zero point 0.3 of zero point 0.3 into D, where big D is your glenoid diameter, and minus the small d is your glenoid bone loss or glenoid defect. So this gives you the area of glenoid tract. Now you have to measure whether the Hill-Sachs falls between this glenoid tract or not. For that, we calculate this interval, or how far is your medial edge of Hill-Sachs located from the medial edge of GT. So how do you calculate it? This is called the Hill-Sachs interval. How do you calculate it? You can calculate the distance between the lateral edge of Hill-Sachs and the medial edge of cuff. This is called the cuff humeral head distance. And you calculate the Hill-Sachs width. And you add both these measurements, you get the Hill-Sachs interval. Now, if your glenoid tract which you calculated is more than Hill-Sachs interval, that means Hill-Sachs is covered by glenoid tract, it's a on-track lesion. If the Hill-Sachs interval is more than glenoid tract, it's a off-track lesion. Only the off-track lesions need to be dealt with. On-track are good lesions, you don't need to deal with it. Okay, so this is just a way of predicting pre-operatively whether you will need to deal with your Hill-Sachs lesion intraoperatively or not. But you can again you can see intraoperatively visualize whether Hill-Sachs lesion is visible or not, and try and external rotate and see whether the Hill-Sachs is articulating with anterior edge of your glenoid or not, and then if that is happening or Hill-Sachs lesion looks quite wide enough or quite medial, then you can deal with it appropriately. How do you deal with a Hill-Sachs defect? Is the remplissage. Remplissage is the most common ways we are dealing with a Hill-Sachs defect. Now, what is remplissage? Remplissage is a French word. It means to fill in. So it was devised or described by Wolf et al. Way back in 2007.